Well, welcome to the Big C in Me podcast. My name is Andy Robinson and I'm a leader of Lifespring Church, the founder of WayMaker International charity and a Zambian NGO of the same name. I'm also a blogger, and you may well know me from social or video media as the Big C in Me. That name comes because a lot of people refer to cancer as the big C, but for me, cancer is the little c compared to the big C that's in me, which comes from Colossians 1 verse 4, which says, Christ in me, the hope of glory. And so that's how I ended up with the handle, the Big C in Me, on Instagram, Facebook, YouTube, and TikTok. And yes, old people use TikTok too. In January 2023, I was diagnosed with stage 4 bowel cancer, and a part of that journey, I've met some amazing people. Some of them were already good friends, and other people I'd met briefly in the past, and some are new friends that I've made through social media since being diagnosed. All of them have been an incredible support to me in different ways, and it's my hope that having them chat on this podcast, that maybe they can be a support to others who are on this journey too. Whilst it was a shock getting cancer diagnosis, for me, the one thing that was totally unshaken by it all was the undeniable belief that God is good. And of course, that medicine is not a second-class healing. I can have the best of medicine and the best of Jesus. And I believe that medics and medicine is a demonstration to the human race that God is good. And one of the things that has been so helpful to me in this season has been my friendship with medics. My wife is a clinical pharmacist, which has been really helpful as I'm on a massive cocktail of medicines. And my friendship with today's guest has been invaluable in helping me understand the many letters that I get sent and understanding what's going on with my treatment and what's happening next. So let me welcome my friend Rohan. Welcome, Rohan.
Hi, Andy. Thank you for inviting me to join you. It's always a pleasure.
No problem. And I'm looking forward to just chatting through some of these questions that I've been asked or that I've had and have going forward. But before we do that, why don't you start by telling us a little bit about yourself, who you are, what you do?
Okay, so I'm Rohan Gunasekera. So I was born in England, spent part of my childhood in Sri Lanka, and came to the United Kingdom, trained as a doctor. I'm a cancer specialist by trade, so I'm a cancer surgeon, and I lead the cancer unit, the upper gastrointestinal unit. So I deal with esophageal and gastric cancer in Liverpool. But more important than any of those things, I'm a Christian. I follow Jesus. I wasn't born a Christian. I grew up in a Buddhist background, and one of the things that really, throughout my training, particularly around the time when I did my doctorate, which was based on physiology and looking at cancer outcomes, was really thinking that there is more to it than what I'd grown up believing, and I grew up believing very much a science-based evolutionist mindset, and I started to question just how perfect the human design is. First of all, how cells interact, how the whole world works, and that kind of led me to Christ. And my biggest passion is seeing people getting healed. And sometimes I get to participate in that process as a doctor, as a surgeon. Other times I get to pray for people and see healing through direct work of the Holy Spirit. So it's a privilege both ways.
Awesome. That's so good. That fits in really well with my best of medicine, best of Jesus. That is so good. And obviously in your expertise in this kind of particular area. So I, as you know, was diagnosed with colon cancer. And I guess it'd be a good place to start. How would you describe what is cancer and like, how do you get it? Because I know kind of some of my thoughts at the time when it first comes, it's like, well, what have I done? Is it my diet? Has it been this? Has it been that? Is it completely random?
It's a great question. So I think, first of all, cancer isn't one disease. I think cancer is a broad umbrella statement over many diseases, but they all have similar characteristics, which are cells that have gone out of control and are dividing rapidly. And so in most cancers, particularly if the organ's in the abdomen, chest, it will be things that are invading other structures and destructive. So broadly speaking, that's what cancers are. They're cells that have gone out of control, dividing rapidly, causing damage. And yeah, as a Christian, I think cancer is from the enemy. It is something that is, it is not part of the goodness of this world.
Absolutely. I mean, we live in a fallen world. We know that, and it's like sickness is part of that. Certainly. So I've certainly come to that position in like, well, I'm just living in a fallen world. I've not done anything to deserve cancer. I don't believe God's given it to me, because I don't believe he can't give me what he hasn't got.
Absolutely. And in heaven, there is no disease. And so I think
Exactly.
I think there are people who are more likely to get cancers, there are certain types of cancers which are genetic. We've talked about risk factors in your case, Andy, and I know certainly look at your family history, you wouldn't expect there to be a clear genetic cause. But for example, people will be aware of some families with breast cancer, for example, where there are genetic risks. So I think it depends on the type of cancer. For example, if you live in Australia, you don't use sunscreen and you're exposed to the sun, you are more likely to get a skin cancer than living in Britain, where it's probably slightly less common. Because of our amazing weather.
Yeah, more likely to get drowned by the rain than burned by the sun. So, I mean, one of the things that I found as it sort of come along is obviously the different stages that medical professional uses, like for cancer, sort of stages 1 to 4, and mine is stage 4, in as much as I've got a spot on my liver. But what are those different stages for? What do they mean?
So again, staging is a word which kind of takes into account several factors. So 3 main factors. So takes into account what we call the tumor stage, which is in relation to a structure where, for example, in the colon, in your case, so most tumors start from polyps or from the innermost lining of the bowel. And so then they will normally go to the next layer, which is the muscle layer in the case of the colon, then reach the outside of the colon, and then breach the outside and invade structures outside. So the tumor stage is essentially, for hollow organs, is the depth of invasion through the different layers from where it started. And now, for example, from the skin, it will be from the surface heading inwards towards the tissues deeper down. So that's broadly what the tumor stage is. Then nodes or lymph nodes or glands is all one and the same thing. So staging takes into account where it started. So the tumor stage, it takes into account where it spread to through the glands, so the lymphatics, and then finally whether or not there's distant sites of disease, what we call metastasis. So that's TNM is the classification system that we tend to use. So rather than calling it stage 1, 2, or 3, most cancer specialists will use what's called the TNM classification. So on your clinic letter, for example, I remember we'd worked through it before you got the letter, but again, it takes into account those factors, and staging then broadly almost groups those groups. So it's easiest to work almost backwards. So stage 4 is when there is presence of distant disease, when there's metastasis. And then stage 3 normally involves node involvement. Stage 2 will often be, a relatively early tumor, but not at the earliest stage. So usually no nodal involvement, but again, there are nuances depending on which organs involved. But that roughly is, and so stage 1 is often very much a localized tumor which hasn't spread. So that's broadly what the different stages mean, which is why you asked me off the record, is there a stage 5, and does it get worse than stage 4? In a not pleasant way, stage 5 would be living in a box.
I guess it's one of those things. It seems. I mean, stage 4, people, certainly my family, when I was talking to my family, the mention of stage 4 suddenly set all the hairs running, because there seems to be this kind of thought that, well, stage 4 is pack your bags kind of thing, which obviously it could be that that conversation of there's nothing more we can do, get your affairs in order. But it also seems to me that, where I am at this point in time is there's a small spot on my liver, which means it's metastasized, but it's still workable in terms of kind of therapy. So there doesn't seem to be a gradient past stage 4.
Yeah, I think that you're quite right. I think stage 4, the problem with the classification, which is why we don't tend to use it for clinical practice, is there's so much variety, there's so much spectrum. So on the one end, you can have a tiny, may or may not be involved area, which is relatively low risk, or you could be, widespread disease, multiple sites in the body with a very poor outcome. So it does vary a lot. Likewise, different tumors behave differently. I remember getting to pray for someone in a church meeting some years ago in one of Randy Clark's healing meetings, and I just just happened to be next to this guy who says we were just praying for people near each other, and just said, Randy Clark said, right, give me a quick overview, just an introduction, and then pray. And this guy says, look, I've got stage 4 cancer. And I remember part of it was just looking at the age of the person. And I said, have you got a neuroendocrine tumor? And he looked at me and said, how on earth would you know that? And I believe, and we operate in things called words of knowledge, where God gives you an inkling. I think this one was probably more just piecing together information. But I just thought, again, God's goodness to just out of all, there's probably 1,000 people in the room, to put someone who knew about this rare tumor right next to this guy who didn't actually volunteer it. But so, for example, there are some tumors like that where you could live for 5-10 years with minimal symptoms. I think for a lot of cancers, stage 4 is serious, which is why naturally people think, gosh, that's not good. It's certainly better to not be stage 4.
Yeah.
But for example, with colorectal cancers, for bowel cancers, in some situations, for example, parts of the liver can be removed and you can be cured even though it's stage 4 cancer. So I think people also, I mean, just if you don't mind me saying, again, there is an element of, some people would say luck, but the way different cancers behave can be different. I've had patients with very, very early looking cancers, but the genetics of them, they behave very aggressively. And people whose disease is so advanced, I saw a lady who, again, I operated on more than 5 years ago, saw her earlier this year. And at the time when I got her pathology results back, and I pray over every patient, I pray for their outcomes, and it is amazing seeing what God does. But even in this lady's case, I remember thinking, gosh, it's going to be an uphill battle. She had a really, really bad pathology result, and you'd almost bet your mortgage on the fact that someone isn't going to do well. And it was great to see her healed at 5 years. And there is an element of how these things behave is different, and there's a lot of research currently being done, really looking at the way tumors behave and the genetics and some of the coding at a genetic level to try and understand why two identical tumors in terms of staging can behave so differently.
So it's fascinating, and I've met. Another episode of this podcast is going to be talking to some of the people that I've met that have been miraculously healed. Actually, I'll send you. I was given a book by a lady here in Brighton. I'll send it to you because she had esophagus cancer with a metal tube in to help her.
Yes, a stent.
Sort of get all that sorted out. And she was miraculously healed. And then they couldn't find the stent. So they've never taken the stent out, which is amazing. I'm like, I was like, at one level, I'm like, oh, wow, great story, cancer healed. I'm thinking, yeah, but that's just God showing off now. So the stent went as well. But I mean, one of the things I've learned, myself through this is, like you're saying, is all the cancers behave differently. The other thing that was quite a surprise to me initially was chemo. So I've done a course of chemo. Isn't like aspirin. It seems to me anyway. Mine was a concoction of drugs put together, and there are many different types, it would seem, of chemo. So I had a PICC line installed, and I was on one called Folfox, which had three drugs in. But people take tablets. There's all sorts of different ones. Are you able to kind of just give us a bit of...
Yeah, that's correct. So again, most people, first question, if you mention the word chemotherapy, is, does that mean my hair's going to fall out and am I going to be sick? Because that's what most of us would automatically think. And the answer to that is actually, for a lot of for gastrointestinal tract tumors, the types of chemotherapy regimes do have those sorts of side effects. But basically, there's a lot of variety. So there are different types of drugs. Often using a group of drugs works better than a single drug on its own. So and the decision as to which drugs are used are partly based on preliminary studies that have been done and seen to be beneficial, and then looking at grouping things. So some of the drug agents, for example, you mentioned Folfox. So some of the drugs in that combination, which is used for bowel cancer, improve the function of the other drugs around. So there can be different reasons for why the concoctions are used as they are. There are some regimes where all of the drugs go through a drip line, such as yours. There are some where you only have tablets. So, for example, some breast cancer drugs are purely tablet-based. So particularly if you're looking at, say, shutting off a receptor, so an estrogen receptor or a specific chemical, then sometimes there are drugs that are tablet form. Folfox has one particular drug, 5-FU, which you know well because you've had a few side effects from it.
Yeah.
5-FU comes in a tablet form, which is called capecitabine. So again, there are different combinations which have been used, and sometimes the tablet form is seen to function better. In other situations, such as yours, the 5-FU, which is the infusion, the one that goes to a drip, PICC lines are like a fancy drip line that stays in the body. So things go into a drip. Ultimately, what you want is, these are poisons that kill off cancer cells. You want to kill off cancer cells. So it's what works best, and it's managing the downsides, because all of these drugs are poisons. So it's looking at the side effects and trying to manage them.
And so why would one's hair fall out?
That's a good question, and the same applies to fingernails as well, because you probably notice fingernail growth stops and you get a line in your nail. So it's to do with how the growth cycle, the cycle of cells reproducing are affected by these drugs, and so it affects how the cells replicate, regenerate. And so as a result, certain bits of the body are affected more. So hair loss, diarrhea, unfortunately, is very similar. It's to do with the cells in the gastrointestinal tract. So those sorts of things are all connected.
And is that because they are also rapidly reproducing cells?
Well, they're cells that their growth cycle are being affected by the drugs. So as a result, they don't behave as they normally would do, because they're being deprived. Some of these drugs work by affecting how cell division works. So there are chemicals that function in the cell cycles. There's a cycle how cells reproduce, and they're kind of interfering with what are called spindle cells, things like that cause some of these things to happen, and they're almost blocking them from happening. So it affects other bits.
So I was offered like a cold cap, which I declined. I thought, if my hair falls out, I think I could rock a bald head, so I'll just go for it. But what does the cold cap do?
Yeah, different things. I think some of it is to do with for women particularly. I mean, it's a huge deal. I think for some patients, I've had many patients over the years where the thought of losing hair is probably the biggest stress of going through cancer treatment.
Yeah.
And people's you'd be surprised how many blokes losing weight is a huge thing, where self-image, looking at oneself in the mirror and just not really being happy with what you see is a really, really common thing with cancer care. So all of these are either dealing with a side effect and trying to minimize it, or trying to slow down. So cold caps trying to slow down the effects of the chemo on the hair.
Yeah.
But again, it works for some people, it doesn't work for others. So
Absolutely, yeah. And I can see that. For me, it wasn't something I was too concerned about. But again, I struggled with other side effects. So I had a lot of tingling in my fingers in sensation to cold, cold things, but only sort of in the kind of 4 or 5 days after chemo, it was that was a real problem.
So some patients can have numb fingers and toes for sometimes years afterwards, sometimes permanently. So, again, it's a spectrum, and how these drugs affect people can differ, and there are more serious side effects. People often know about sepsis, infections, and that can be fatal. Things like blood clots, heart attacks. There are effects on kidneys, and there are some really serious side effects as well. But ultimately, it's all about, if there's benefit to be had, then clearly that's why you use them.
Absolutely. And so what's radiotherapy then?
So there's, I suppose, 3 main types of treatments people will hear about. So there's chemotherapy, is drug treatments, which are killing off cancer cells. Then you've got radiation treatment, which is often in conjunction with chemotherapy. So we talk about chemoradiotherapy. It's both together. So radiotherapy on its own is essentially focusing the radiation beams, a bit like the principle of using a magnifying glass with the rays of the sun and burning a piece of paper. It's exactly the same concept, but X-rays are essentially invisible, and it's focusing a beam on a set area of the body. So what will normally happen is the anatomy of where you're targeting is mapped against a CT scan. Patient will have some little tattoos, little dots tattooed on their body to triangulate, to sort of focus that beam where it needs to go. So normally there'll be at least 3, sometimes 4, and so that you don't have to keep having, trying to figure out where it needs to be. You can use those points to target. And that treatment will be planned treatment depending on how many cycles, how many grays worth of energy are required. So people will normally go, say, for example, once a week for 5 or 6 weeks and have the dose of radiation, and the total dose is what you're looking at. So how many fractions, so the division of how many times you go is based on how many fractions that you have. So again, that can be done either just on its own, so that's what you call radical radiation, or chemoradiotherapy is more common, which is where you have a drug to help the benefit of the chemotherapy. The chemotherapy will help the radiation work better, but again, it carries more risks. So that's radiation. And there's another family of drugs called immune therapy, and immune therapy is the new kid on the block, I suppose, in a way. And there's been quite a lot of really significant improvements seen with certain types of immune therapy. A lot of work done into targeting a family of things called checkpoint inhibitors, which are almost things that can shut off cancer cells.
Wow, that's amazing. And I think it's obviously those things are reducing the tumor and killing it off, one hopes, as well. Certainly that's where I've been. Now, one of the things that I know, again, I've learned is that, I guess amongst cancer patients, we often say you're only as good as your last scan. So whatever plan you've got is only as good as your last scan, because when you have another scan, then there's another plan. And so I guess I wonder, what is it that, obviously when I was on chemo, I was having a blood test just before every chemo session. I've just had today an MRI scan following chemo, and I've got a CT scan coming. Prior to all of this, I had a PET CT scan. I wonder if you could kind of just very briefly and simply explain what all those tests do and what they tell you.
Sure. So CT scan is a fancy X-ray where you essentially lie on a table, go through a machine that looks a bit like a polo mint shape. If you live in the UK, you know what polo mints are, a round coloured sweet. And takes about 5 minutes. Usually you have an injection of usually a contrast dye that helps to show up different phases. So CT scans can be done in different ways. So I suppose the best analogy is you can take photographs of a portrait. You can take a picture of someone's face or the background scenery, and you're looking for different things. So often you do the scan in different phases. So there's what you call an arterial phase. So that's when the contrast dies in the arteries, in the main blood vessels coming out of the heart. Then you can do a delayed or a portal venous phase. So where you have it at a slightly different point that can be useful in the liver, for example. And CT scans nowadays, the resolution power is down to about 5 mm size, and they're probably the most important scan most people have. So it's really looking at the anatomy. And if you remember back to the T, N, and M tumor stage, so looking at which bits of an organ are involved, are there any nodes involved, are there any distant sites of disease? So that's probably the most important one. So PET scans came into regular usage in the UK about probably 20 years ago, just a bit short of 20 years ago. They work on a different principle, but they work in a complementary way. So PET scan, the stuff that's injected into you is a type of sugar. We said that cancer cells are cells that have gone out of control. So they're dividing rapidly, so they eat up sugars faster than cells around them. So what you expect to see is a PET CT scan so PET is positron emission tomogram. Okay, so positron emission is from these cells eating up sugars. And again, PET CTs, it still uses a component for anatomy. So just to superimpose that on the anatomy you've already seen, often on a high resolution CT scan. So PET scan is looking at metabolic activities. It's looking at cell activity. And what you'd expect, for example, in a bowel cancer, you'd expect to see uptake of the sugar in the area where you already know there's a tumor from the CT scan. So you get a hotspot. So it's a bit like a thermal imaging camera on a police helicopter and looking for a kind of a robber running away from a stolen kite. It's the same thing. You expect to see a hotspot, but you can also see hotspots in other areas. And so about 10% of patients will see other sites of disease that haven't been seen on a CT scan, or other areas that need to be looked at, which can be incidental. So that's PET CT is actually quite an important addition. But if you had to pick one scan, it will be your CT scan. But PET CT probably stops a small percentage of patients having treatment that won't benefit them because there are unrecognized occult areas elsewhere. So those are the two main ones. MRI scans are used for certain areas. So for example, below the pelvis, so lower down, it's looking at soft tissues, and it's very good at looking at soft tissues. For head and neck tumors, again, it's really good for looking at those sorts of areas. And again, it's looking at are certain tissue planes intact or not. And so that can be very useful. Some areas, instead of using an MRI scan, would tend to use ultrasound scans. So ultrasound is bouncing sound waves off a probe. So for example, you can put that down a windpipe and you can do an endobronchial ultrasound, or you can do it through like a camera down the esophagus into the stomach, and you can look at areas using that. So those are the main modalities used. Occasionally there are invasive procedures where you put a telescope into a body cavity, so laparoscopy, or into the chest, thoracoscopic assessments where again you can do scans that way as well.
Interesting. And I understand that there's lots of slices they take.
That's exactly right. They reconstruct. Yeah. So they basically, these fancy machines, what they do is they're powerful computer software programs that piece together these slices taken closer and closer together. So if I think back to, I started training well, it's more than 30 years ago now. But in those days, the CT scan, the slices were much further apart, so you could miss things in between. Whereas nowadays, they've been able to manage these by not giving people massive doses of radiation, but being able to get these slices much closer together. And so this is where the different modalities have different ways. So MRI imaging, for example, doesn't use radiation. It uses magnetic resonance. So MRI is magnetic resonance imaging. So again, uses that as a modality. So probably, in some ways, in the longer term, is safer because there's no radiation dose.
Interesting. And my final question for you is the formidable MDT meeting. Yes. So this seems to me, as a patient anyway, there's this big meeting that happens where I don't know what happens really. Multidisciplinary team, I believe it stands for. But what happens there?
So an MDT meeting is basically, it is from 1999 in the UK. Cancer care was far more standardized, often into regional specialist centers or into local teams. So you've got different people represented in a MDT. So you have your core members. So as a surgical oncologists, you'd have a consultant surgeon there, you have a group of people. So again, the idea is you get a consensus opinion rather than just one person's view. You'll have clinical and medical oncologists. So a clinical oncologist is someone who deals with giving radiotherapy. A medical oncologist is someone who deals with giving chemotherapy drugs. So you have those two. You have, say, for example, a gastroenterologist. That's a physician who deals with looking at the gastrointestinal tract in the case of bowel or esophageal or gastric cancers. There are other groups, for example, in breast cancer, where things are done slightly differently, but they'll have a one-stop shop where you have a radiologist. So again, for most of us, one of the key people to be there is a radiologist. That's someone who deals with X-ray investigations of all these different types we've discussed. And what we'll normally do is we'll review, first of all, a summary of the patient. So it might be a new patient, might be someone who's been discussed before and been followed up. You summarize where things are up to, and there's a system in the UK called the Somerset Cancer Registry, which is used by all trusts, and the information is stored in a way that is very much the same for all hospitals. And the idea is then you look at the imaging, you look at the story, if there's genetics to be taken into account, you look at all of those, and then you have a discussion. And for most of these, there are national protocols as to the decision making and guidance. But the main, I guess, purpose of a MDT is particularly to make sure you're tailoring the right evidence for the right situation, and sometimes there are grey areas. There are areas that fall between stools, and it's particularly those discussions as to what's the right treatment here. And sometimes it's really looking at various options. It might be there are several options which are realistic, and looking at what are the options, and then going back to a patient and saying, right, there are several options here, and being able to offer based on the best evidence. And there are always patient factors and disease factors, so you've got to match what is best for an individual. So that's really what happens. And there are specialist nurses in our MDT because of the nature of what I deal with, dietitians, pathologists. So you may have a histopathologist who's someone who deals with looking at microscopic specimens and presenting those at meetings. So there's quite a lot that goes into MDT meetings, and there are MDT coordinators in pretty much all hospitals who deal with collating the information, making sure it's recorded properly on these Somerset Cancer Registry databases.
That's really helpful for me to know, because it's a black hole of what happens. It's just nice to know kind of who's there, because obviously, like next week there'll be an MDT meeting with my name on it somewhere. Following my scans, where they'll decide, if the liver needs to be operated on, whether they go for that first or whether they do the colon first or whatever. So that's really interesting. And I think we have our Macmillan nurses there as well, who are superb. I cannot.
Yeah, it depends on the area, the organ system, and so very much dependent on that. But there's a lot of people who go in, but again, most of us will have pre-MDT meetings. So several days before the actual main meeting, you have a prior meeting to try and limit the number of people actually being discussed, to make sure all the information's there for patients, because it is a key meeting. Like you said, it's if any one of the key bits of information that are being discussed aren't available, you're looking at a delay for a week. And we're always looking to have treatment completed and, or investigations completed and treatment started within 62 days of a diagnosis. So it's a pressure to make sure people get through the system quickly.
Yeah, and that was great. I mean, mine was, I think, 2 weeks. They'd had an MDT meeting and a plan had begun within 2 weeks, which was amazing for me. Anyway, so that's been great. Rohan, thank you so much for answering those questions, being with us on this podcast. I'm sure that would have really helped a lot of people. And as always, you take very complicated things and make them understandable, which I'm very grateful for. And for your friendship and support and encouragement, both medically and in terms of faith and healing and all of that kind of stuff as well. So thank you so much for that. Thanks for being with us.
It's a pleasure.
No, it's great. It's been brilliant. And just again, for everybody, if you want to give us a like on the podcast, that would be really helpful. And do tune in with us next time. Thanks for joining us.
Take care. God bless.